So we talked about clinical study follow-up length. How long are you both following clinical outcomes? And Oz, should we be following out to 12 months in clinical practice? Is that really relevant? If you have 12-month data or 24-month data, do you need to follow clinical practice out to 12 months? Oz, I'm going to give you no. Sid, I'm going to give you yes. Or 6 months, I should say. Oz, you get less than 6 months. Sid, you get more than 6 months.
Yeah, I mean, it's hard to argue this, but I'll say, I think objectively you probably should be following these patients. But the question is, what's the standard of care if you're doing this procedure outside of a trial?
That's what I'm getting at. Yeah.
Yeah, if you're doing this procedure outside of a trial, the reality is even if you want to follow them for longer than 6 months, good luck.
It's not easy.
Most of these patients are very, very difficult.
It's not easy.
So that would be the only argument that I could make to sort of say, well, you don't really need to follow them 6 months, is because you probably couldn't even if you wanted to.
Yeah, and it depends on what type of follow-up you do. Are you talking about in person? Are you talking about telephone? Are you talking about video, right? Are you talking about being in a big city like Chicago or Los Angeles, or in a small town where people have easier access to, or, are your patients local or are they far away, right? So that all matters. We do almost every patient on trial. The ones where our protocol has been a short-term follow-up at 3 months, and then we do another assessment at 1 year. We prefer to do the 3-month one in person, and the 1 year one is optional in terms of in person versus tele. But as Oz said, that 1 year, sometimes patients don't want to come in. Also, if it didn't work, right? Let's say they didn't get any benefit at 3 months. Do I have to see them at 1 year again? To say, hey, did it start working again? No, it's not going to work, right? If it didn't work at 3 months, it's probably not going to work. So then you probably don't need to see them. And then, of course, it depends on your capacity, right? Like, what is your office capacity? What is your clinic like right now? Are you already full? Like, can you afford to absorb a whole lot of clinic appointments? Those are the realities that we have to look at. As an example, like my clinic is pretty much runs at around 90 to 95% capacity. So even adding extra visits is a huge burden on our clinical practice. In fact, most of my partners, our clinics are pretty much full, and all of us have a lot of clinic time. And so adding things in, it's not that easy.
Well, it's not cancer. You're not looking for recurrence, right?
Right.
So it's a different ballgame. So you don't follow between 3 and 12 months, Sid?
On trial, we do.
Okay.
We do Q3 months.
Yeah.
But these are off trial. I don't think you need to follow them that closely because, as you said, we're not looking at tumor response, right? I don't need to. If they recur, they'll call me, to be honest, right? So I don't need to pick it up as soon as they recur. I don't need to find out. It's not like a tumor, right? I want to find out sooner rather than later. But in this. Or a lot of times, you could just say look, if things come back, things change, things get worse, contact my office, we'll set up an appointment. You can kind of do this PRN type of follow-up as well after your first initial follow-up.
Oz, what are you doing currently?
Yeah, so I think this is a very academic answer, but my sort of hack to try to get better follow-up was to create a registry, right? And then now I have basically my own mini research army that basically is dedicated to just calling and trying to hounding these patients post. Just kind of like Sid said, on trial kind of approach. So we do 3, 6, 9, and 12 months as part of our registry. And again, I don't have to depend on our clinical staff necessarily to get them to follow up and get all that data. Just gives me additional sort of support to do that, because I think what we found clinically, if patient wasn't on trial or wasn't on any sort of study, it's exactly what Sid said. If they didn't get better at 3 months, they literally are saying, well, why do I need to come back? And I don't have a good answer for them, for why to come back, other than I just want your Womack,
Yeah.
And
Sure.
even for the trial patients, we tell them, look, even if it doesn't get better, you're still coming back. And if you don't like that, I'm not letting you sign this consent form. All right. We're pretty strict. You have to do the follow-ups. And if you don't agree to it up front, then you don't fulfill the inclusion criteria, right? And our compliance on trials has actually been surprisingly high. Not perfect, but high. But yeah, off trial, people are not going to want to show up, right? My clinic is $20 to park your car, right? No one wants to come to my office if they don't have to.
Well, and I think in this age of telehealth and video visits and phone calls, it's a little bit easier, I think, sometimes. But on trial, that's not always feasible. I get that.